Thanks very much. So what I'd like to do is share with you results of a new study we did on microbiota transplant for children with Pitt Hopkins, which is a very rare condition related to autism. This is work done primarily in collaboration with my long-term microbiome collaborator, Rosie Krajmalnik-Brown. It was funded by the Pitt Hopkins Research Foundation, who actually approached me when they saw the success of our study for children with autism. They asked us to do a study for their children. I also want to thank the Brain Foundation and the O'Sullivan Foundation for related support, as well as N of One and Autism Research Institute and a number, 1,000 plus parents. I do have a number of disclosures I just need to go through briefly. So, treatment and is not yet approved by the FDA for autism or Pitt Hopkins. I'm the co-owner and president of the Gut-Brain Axis Therapeutics, a small company that we formed in order to commercialize MTT for Pitt Hopkins. I'm also part owner of Autism Diagnostics. I'm president of the nonprofit Autism Nutrition Research Center and receive grants from them. And also we have a collaboration with Sun Genomics and funding from them on a large probiotic treatment study. So what I want to do is first talk about Pitt Hopkins. It's an extremely rare condition. It's a neurodevelopmental disorder characterized by either a mutation or deletion of the TCF4 gene on chromosome 18. It affects about 1,400 people in the United States. The diagnostic test was really only developed about 15 years ago, so there are probably a number of adults who have not yet been diagnosed. It is a very severe condition. It includes severe autism, so most of the children cannot speak. It includes severe intellectual disability. Their developmental age is about that of a 1-year-old. And it includes severe physical disability. They have some facial deformations, some hand deformations. Their feet are especially deformed, so it's hard for them to walk until some of them will have surgery. So they will often be in wheelchairs. And the biggest issue that we're going to focus on for them is that they have long-term chronic constipation causing a lot of pain. So 80% of children and 70% of adults suffer from long-term chronic constipation. As you'd somewhat expect, they have poor muscle control of gross and fine motor function. We suspect that also affects peristalsis. So there's probably weakness or poor coordination of the muscles pushing the food through the GI tract. And also, because they have very low activity levels, many of them spend most of their time in a wheelchair. That alone would contribute to chronic constipation. So there are a number of features, including about 30% of them are fed by G-tubes. This is a direct quote from the director of the foundation, who's also the parent of a child with Pitt Hopkins. The bottom line is that GI pain is a major or the major factor in the quality of life for these children. So I'll just read the quote from her. Children with Pitt Hopkins are often in a great deal of abdominal pain. For example, my son has daily pain. I can tell because he's agitated and sometimes cries because of it. Most children with Pitt Hopkins wind up in the hospital because they are in so much pain. When my son has a bowel movement, the pain decreases, but it can return within a couple of hours, depending on how severe it is. Most of our parents would say whenever their child seems uncomfortable, upset, the gut is the first thing to look at. So just to make sure that everyone's aware of FMT for C. difficile. C. difficile infections cause a life-threatening diarrhea. Used to be in about 500,000 people, now it's a bit lower. COVID helped with that. And it used to kill about 29,000 people a year. It's severe life-threatening diarrhea. It can be treated with antibiotics, but it can often return. FMT has been found to cure C. diff within 2 to 3 days after typically 1 to 2 doses, with about 90% success rate typically. And essentially, unlike with antibiotics, when you're treated with FMT, you're essentially cured lifelong. And it's almost unheard of for it to return after that when it's been initially treated. FMT has now been used by hundreds of hospitals in the United States to treat over 50,000 patients with C. diff. And I have to correct the last line. Just this week, It is now approved by, a particular version of FMT has now been approved for C. diff, just as of a few days ago. So very exciting. So why do we want to consider microbiota transplant for children with Pitt Hopkins? And we use the term microbiota transplant because with C. diff, 1 or 2 doses is plenty. Whereas we've learned for autism, it's much, much harder to treat than a simple C. diff infection and seems to take daily intervention for many weeks or months. And that's why we use the term microbiota transplant, because it's, and I'll come to the details of the therapy. But the reason we want to consider it for children with Pitt Hopkins is we published a study a year ago led by the American gut team, and we just had a small role in that, where we looked at the alpha diversity. And basically, the higher diversity, the higher number of species of bacteria in your gut is generally believed to be a healthier gut. So children with autism have lower diversity than typical children, meaning they're missing, of order 100 or so different bacterial species, perhaps, depending on the study. But children with Pitt Hopkins have an even lower diversity than children with autism. Also, we asked the American Gut to look at 3 Clostridia that are especially commonly reported in children with autism, and one of those 3, C. boltiae, was found to be of order 100 times higher in children with Pitt Hopkins compared to their parents. In some cases, it's 10,000 to 1,000,000 times higher in these children. We don't know a lot about C. boltiae. It was actually named after an autism mum because it's a bacteria first discovered by Sid Feingold in children with autism. But we have a strong suspicion that it's a nasty pathogen. We went ahead to plan this clinical trial for microbiota transplant for Pitt Hopkins. It turns out this is actually the first clinical trial of any type ever done for children with Pitt Hopkins. So to do this trial, we had to develop our own ad hoc questionnaire to assess Pitt Hopkins symptoms, as well as use some other questionnaires. So we made a few mistakes along the way, but we've learned a lot too. So in design, we jumped directly into a phase 2 study because we had previously done an autism study. If you're not aware of that, very briefly, in our autism study, in our phase 1, we found 80% reduction in GI symptoms, initially 23% reduction in autism symptoms, and then at a 2-year follow-up, 2 years after treatment stopped, there was about a 59% reduction in GI symptoms, so a little bit lost over 2 years, but about a 47% decrease compared to baseline in autism symptoms. Now that was open label, so there's some placebo effect. But now we're doing randomized double-blind studies for autism, and I'll report today we're using a very similar design to this for our Pitt Hopkins study. So in part 1, randomized double-blind placebo-controlled, half the children get treatment, half get placebo. And then in part 2, the treatment group is just observed, and then the placebo group is switched to the real treatment. So we break the blind at that point for the parents and the study coordinator, but not for myself or the physician. And then in part 3, we just do another 3-month evaluation. So basically, we're following them 3 to 6 months after treatment. Our concern is because these children have low physical activity level and probably weak peristalsis. Our concern is we might be able to treat it, but only temporarily, and they might lose benefit after a few weeks or a few months. So we had a lot of unknowns going into this study. So our treatment was to use 10 days of vancomycin therapy to eliminate harmful bacteria, a 1-day bowel cleanse, and then microbiota capsules for 3 months. We used a high dose for 4 days, and then a maintenance dose every 3 to 4 days for 3 months. We used microbiota capsules by our collaborators at the University of Minnesota from very healthy, very carefully screened donors. The criteria we used, basically these are what we believe to be the top 5% or so healthiest Americans. So very, very healthy, carefully screened donors. We planned to enroll 10 and then up to 20 participants, but we did not know going into the study that most children with Pitt Hopkins were so intellectually challenged and physically challenged they could not swallow pills. So we were able to enroll only 7 children, And one of the child dropped out after a few days because they could swallow a pill once in a while, but they had to swallow multiple pills for some of the days, and they could not do that. So we had 6 participants who were able to swallow pills consistently, and they completed the entire study. No dropouts all the way through end of part 3. 3 were randomized to group A, and the 3 were randomized to group B. So this is a small study, but I'll point out with the FDA, their criteria for very rare conditions like Pitt Hopkins is that a single trial of order 12 children is enough for drug approval. So if we see the example they give is if you see improvement in 3 of 12 children, that's enough for drug approval for very rare diseases. So first I'll share with you the outcome of GI symptoms. So we used the same questionnaire we had used for children with autism, and this is an average of 15 different symptoms. These children had significantly worse GI symptoms than the children with autism. The blue bar on the left is the children at baseline in the treatment group, and the orange bar is the group B, who are initially placebo. And then what we see is at the end of part 1, there's been a big decrease, averaging over 15 symptoms, and 1 is the absolute lowest possible score. There's been an 80% reduction in GI symptoms in the treatment group, and the placebo group had only a 30% reduction. I was a little puzzled it was that high, but a gastroenterologist who's here today explained to me that there's often a high placebo effect in GI studies. So then in part 2, when the placebo group was switched to the real treatment, they improved a lot as well. And then in part 3, we held our breath and waited. Because these children are in wheelchairs with low physical activity, because they have very poor hand, gross and fine motor function, would they lose benefit? And we were thrilled to see that at the 3 to 6 months after treatment had stopped, the benefits were holding, that there was no loss in GI improvements. So overall, 84% reduction in GI symptoms compared to baseline, a very significant p-value for such a small group. If we look at the subscales of the GSRS, there are 5 subscales, each representing about 3 items. The first is the GI subscale for pain, and as you can see, there are very high pain scores here. The treatment group, huge decrease in pain. The placebo group, just a small decrease in pain. And then when the placebo group was switched to the real treatment in part 2, they had a large decrease in pain as well. And then that continued 3 to 6 months after treatment was stopped. With reflux, that's the one score that's different, because it turned out that none of those kids in group A had any reflux symptoms. It was only reflux in the group B children. But during placebo, there was a small reduction in reflux. But when they were switched to the real treatment, reflux was essentially eliminated, and it stayed eliminated 3 months later. For diarrhea, subscale, again, some symptoms here. At baseline, treatment group, problems are eliminated, placebo group, small decrease, and then end of part 2, more improvement, and end of part 3, even more. GSRS indigestion scale, stomach rumbling, etc. These issues, again, had very similar improvements. And then constipation, which was the biggest problem for these children, a large improvement for the treatment group, less in the placebo. And then as time went on, the placebo group had some improvements, although not quite as much. We also had a pain scale. This is a special pain scale designed for children who are nonverbal. So the FLAC stands for F is for face. So the parents judge pain looking at the child's face. Looking at L is for legs, seeing if they're squirming. A is for their activity level. Are they curled up in a bundle because they're in pain? C is for crying. And the second C is for consolability. Can hugs from the parent console them? So it's a 0 to 10 scale. It's just a 3-point scale. And we see a baseline. They're in substantial pain, averaging a 5.5 out of 10. And this is essentially every day of their lives. And then we see a big decrease in the treatment group, a 70% decrease in the treatment group, but 47% decrease in the placebo group. and then more decrease in the placebo group when they get the real treatment, and 3 months later, still a big decrease. So roughly a 79% reduction in pain, very significant on this very crude pain scale. We also created a special questionnaire, as I mentioned. We used a questionnaire we'd previously created for autism, and then added in 9 symptoms that were specific to children with Pitt Hopkins. Some of them have hyperventilation, for example, so they'll just breathe very, very quickly. Some of them have air swallowing, so they'll swallow big gulps of air down their throat. They have ataxia, their hands and arms just seem to move randomly at times. So they have a number of additional symptoms beyond autism. And so we were wondering, could we help any of those symptoms at all? So this is a reverse scale where 0 means no change, 1 means slightly better, 2 is better, and 3 is much better. So the treatment group improved about twice as much as the placebo group, averaging over 29 symptoms. And then 3 months after we stopped treatment, the treatment group continued to have more improvements, and 6 months later they were doing even better, which is similar to what we saw in autism, that after treatment the benefits just kept on improving. And the placebo group did not improve as much when they were switched to the real treatment initially, but then longer term they had more improvements as well. So some variation there, but overall we're thrilled to see any improvement in the other symptoms. We think a fair bit of it is just the parents would say anecdotally, my child's not in pain anymore, they're not biting and scratching me, that because they're so in so much agony, they're now much more pleasant and just seem happier. And so if we look specifically at the single question on the PGI about GI symptoms, so this is just one question, but overall we see the treatment group improved more than the placebo. When the placebo group was switched to the real treatment, they reported their GI symptoms were better. And then 3 to 6 months later, again, both groups saying those GI benefits remained improved. Not cured, but substantially improved. If we look at the specific symptoms that improved, so again, a 2 is better, a 3 would be much better, and 1 is just slightly better. I would say the symptoms on the left are probably real, and the symptoms on the right, probably a fair bit of that is placebo. But it's interesting to see that irritability and mood improved almost as much, essentially as much as the GI issues. So that, again, corresponds to our idea that pain is a big issue we're reducing. Overall symptoms, so this is an overall question, and the overall symptoms of your child. They saw a lot of improvement, better social interaction. The children would want to be with their families now as opposed to in their rooms. Better anxiety, better tantruming, less rashes. These children often have rashes. Better gross motor. Some of the children could walk farther than they could before. Stimming and perseveration, aggression, receptive language, eye contact, fine motor, expressive language. So those are all symptoms that seem to improve. The other symptoms on the right all improved to some extent perhaps, but it's probably more placebo effect. A daily stool record, although that was our primary outcome measure, we realized unfortunately was very complicated for these children because they were all on substantial GI medications, laxatives, rectal enemas, suppositories, because they were so severely constipated, they had to take those. But despite taking those medications, which they started the study with, they still had a lot of bloating, they still had a lot of gas and pain. So those supplements were able to help them have a bowel movement every day because the parents gave them high doses when needed, but it still was not emptying them out. So in part 1, we see both groups improve a little bit. The treatment group improves a little bit, and then when the treatment group is switched to placebo, it improves a little bit more. And then unfortunately in part 3, there was one child who had a nutritional shake that they drank large amounts of, but it became unavailable halfway into part 3. So when they couldn't get their nutritional shake, they stopped drinking as much and became constipated. So they were free of medications up to that point, but then they had to restart medications. But what complicates the daily stool record is that many of the families were able to stop or greatly reduce their GI medications. So now they were having daily bowel movements, but without needing a rectal enema or a laxative or a stool softener to achieve that. So 4 of 6 participants were able to greatly reduce or stop their GI meds, and 2 partially reduced their GI meds. So that makes analysis of the daily stool record complicated. But our interpretation is that basically their bloating greatly decreased. So now they were having a bowel movement every day, but we presume they were not nearly as backed up, and they had less gas as well, because again, that bloating had disappeared. And also they seemed to have much better emptying when they had a bowel movement. By the way, all of these children were in diapers. They typically need them lifelong. And so that means the parents can capture and see every single bowel movement, which is a great advantage for a research study. And so one of the most important parts of the daily stool record, though, is the number of days with pain. So at the start of the study, the treatment group on the left reported a very high frequency, but of the 3 parents in that group, only 1 felt comfortable that they could interpret their child's symptoms well enough on a daily basis to say if they were in pain. So 2 of them in the treatment group did not report data on this, but on the GSRS, they said yes, there was a 83% or 100% reduction in GI pain, but they didn't do it every day, unfortunately. But that one child went from 13 out of 14 days of significant pain to 0 days of pain and stayed at 0 during the rest of the study. The placebo group increased their number of days of pain while they were on placebo, and then when they switched on the real treatment, the pain disappeared and then remained mostly gone, except for that one child who had lost access to their nutritional shake, unfortunately. So to summarize our results, for all the treatment measures, for most of the treatment measures, we saw a very similar response. For the GSRS, the pain scale, the average of 15 Pitt Hopkins symptoms, and the GI symptom in particular, the treatment group improved more than placebo, not statistically significant because we only have 3 children in each group, but I think clearly more. The placebo group then improved when they were treated, and the benefits were stable, or actually often even just improved more when the treatment stopped. That's one of the exciting things about this treatment, is that it makes us think the treatment will be very long-lasting, at least lasting 3 to 6 months, in children with very low physical activity level who we thought might have a recurrence of constipation. But the daily stool record, we would say that the treatment group does improve, but the key thing is that 4 of 6 participants were able to greatly reduce or stop the GI meds, and also there was a 97% reduction in days of pain by the end of part 2. So our interpretation again is that incomplete evacuation leads to backup of stool and gas, which caused a lot of GI pain and worse behaviors. And it's interesting that we had several children with reflux, and that reflux was also treated. And you wouldn't think reflux would be directly due to the gut bacteria, but indirectly, that if you're able to remove the constipation, then presumably that reflux was due to, there's nowhere else for it to go but back up. I'll let the GI doc say that more elegantly. Forgive me. But basically that's what we think was happening. The MTT reduced the bloating and the pain and the GI symptoms, and we think that alone improved some of the symptoms, the irritability, the social ability, the anxiety, and the tantrums. And so that was very exciting to us, and to see that those benefits seem to be lasting 3 to 6 months later. So I won't share with you the microbiome results. My collaborator can share that another day. But to tell you, the exciting thing is that we've shared the results with the FDA. We're waiting for one more piece of data from some microbiome measurements. We found at the start of the study that 100% of the children had either high levels of Clostridial, one of 3 pathogenic Clostridia, or high levels of yeast. So we're now waiting to see if our measurements of that changed. So we are going to we're asking the FDA, can we file the equivalent of an IND? It's actually a BLA because it's a biologic. So they're going to think about that, once we have the answer. It's a long shot because we have so few children, but roughly 300 drugs have been approved for pediatric rare diseases. So I filed for a pediatric rare disease application. I filed for orphan drug designation, so we're keeping our fingers crossed. Our next step is because most of these children could not swallow pills. We're now working, I should say my collaborators at the University of Minnesota have developed a liquid version, and we're going to be submitting that to the FDA, and we plan to do a follow-up study with a liquid version, because then that will be acceptable to as many more children with Pitt Hopkins and perhaps other people if it's eventually developed for them. So we've been working on fundraising. We have two groups, the Pitt Hopkins Foundation and another investor who have committed to support us to do this next study. And so we're very hopeful. So we want to thank again the Pitt Hopkins Foundation for funding our work, the families for participating in this study. For kids with autism, it's hard enough for them to be involved in the study. For kids with Pitt Hopkins, it was probably 2 to 3 times harder for these families. There's just so much more intense care is needed for these children. They have to monitor their breathing, they have to monitor their food, etc. Many thanks to our research team and our study physician and our microbiome team, and especially the University of Minnesota team for providing the microbiota capsule. So hopefully I talked fast enough that there's time for a question or two, but I'm not sure. So thank you all.